Doing well. We're all doing well.
Good, April. We're doing good. Nice
Awesome.
to meet you.
Awesome. Nice to see you again, Fernell, as always.
All right, everybody. Why don't we jump in? I'm sure we'll have a number of other folks stagger in. So, welcome to our second speaker series of this month, addressing racism in healthcare. Just a couple of um, administrative items, and many of you know this already. We'll use the chat feature as our questions. So up on the right hand, in the right hand upper right hand corner, you'll see the chat box, the box with the 3 lines in it. If you just want to hit that, you can ask questions, and I'll manage that along with Vince. And we'll and also the comments as we go back and forth on anything that you want to share with the group. I would ask you to keep your mute buttons on if you could, and you can certainly have your videos on, or you could turn them off. I would just ask if you have them on, and don't have yourself in any compromising positions that will distract from the dialogue, because we know we've experienced that a little bit as well. So, welcome everybody, and I have the privilege of introducing our speaker tonight and facilitating our session. So I want to welcome Dr. Vincent J. Daniels, DMD, to our session tonight. Dr. Daniels currently serves the greater Newcastle County, Delaware community as dentist and has his own dental practice, Blue Diamond Dental, PA. Dr. Daniels has been practicing general dentistry since 1991. After graduating from Temple University, he practiced as an associate with 2 prestigious group practices in Philadelphia, Pennsylvania. When the opportunity became available, Dr. Daniels bought one of the most well-respected dental practices in Wilmington, Delaware, from Hammond Knox DDS. Blue Diamond Dental was established as an opportunity to provide stellar dental services at a level that would enhance the patient's oral, dental, and personal well-being. Dr. Daniels has been a dentist for over 18 years, graduated from honors from Temple, as I mentioned, and began his dental career as an associate in Philadelphia and now is in Wilmington. Dr. Daniels is a member of such prestigious organizations as the American Dental Association, the American Academy of General Dentistry, the Delaware State Dental Society, the New Era Dental Society, and the Total Case Management Study Club, as well as the Newcastle Dental Study Club. Dr. Daniels most recently received the Littleton P. Mitchell Award from the Metropolitan Wilmington Urban League and the Wilmington Award for Excellence in Health from the City of Wilmington, both due to his strong ties and commitment to excellence in dentistry and community service. And his motto is, he's completely committed to his patients, and it's truly a pleasure to serve them. So, Vince, welcome. And before we jump in, I also want to really thank Vince for taking the time out to speak with us and educate us on, his history of working with racism, dealing with racism, and the actions that he has taken to help eliminate racism. And in particular, I want to thank him for the time, because as you can imagine, being a medical professional during this time is very challenging, particularly with the virus and the vaccine. And we'll get into a little bit of dialogue on that, because Vince has some really insightful real-time experience on vaccine distribution and how it's going, the factors that go along with that. So Vince, welcome, and we really appreciate the time.
Wow, it is a pleasure. And first, just let me give a special thank you to Common Bonds, to Mike and April in particular, and certainly the board, just for having me tonight. It's just a supreme honor to be able to be part of this series, the Zoe Rogers Speaker Series. And I understand that we miss Zoe, and certainly it's an honor to be part of the series that's gotten going here. And I'm glad to be here tonight.
Great. Thank you for that. So we normally start just with asking you a little bit in more detail about your background, your upbringing, where you were born, where you were raised, what type of personal experiences that you had in being brought up, and any challenges that you had within your upbringing, particularly as it relates to being an African American male, and experiences that you may have had with racism and how you had to handle those.
Well, Mike, I'd like to just say I was first born in Harlem, New York, up in New York City. but I was raised in Pittsburgh, Pennsylvania. So I actually am a Pennsylvania guy. K through 12 was my education in the public school setting. Um, I was basically brought into my aunt and uncle's family at 9 months old. I was about 3 days from going into foster care. My mom had had a mental breakdown, and my brother and I were caught between whether or not family members would be able to step up and stand in that gap for us. And had it not been for that, I probably wouldn't be here today in front of you guys. So, I've always remained humble in terms of, being able to be about, or just having an opportunity to be, available and be in the process because, as they say, there before the grace of God go I. So I was raised in a family out in Pittsburgh where there were 7 other children. So I was the 8th, which meant that, pecking order to eat sometimes was a little tight.
Yeah.
But, it was a warm, loving family. And it allowed me the opportunity to come and being engaged and being grateful about this process. And so, as I said earlier, I was K through 12 in terms of the public school system out in Pittsburgh. We were basically about 50% breakdown in terms of what the racial components were in the school system where I was at. It certainly showed early that, when you got into the honors programs or the AP programs, that there may be 3 or maybe 4 other Black men or young men in that same program. So you kind of knew early that, even though the school was at 50% or more, the more challenging areas tended to be less and less occupied by those looking like yourself. So early on, that kind of allowed me to know that the things weren't always even and equal, even though some of my friends were in there and other ones weren't. But it lended that, I was able to actually leave and understand that the ceiling, especially the glass ceiling in the Pittsburgh area, was fairly low relative to minorities. There was never a Black mayor or a mayor of color. There was no one on the city council during the time that I was there. Most of the jobs and situations that were available to most folks, you tended to be not management, but more or less on the labor side. So, there were a handful that actually were able to ascribe to that part. But as I went through the journey, it was important that, the education piece played a role. I was a 3-sport athlete and had some opportunities to play in college, but I actually was able to gain an academic scholarship to Morehouse in Atlanta. So my undergrad experience was at Morehouse. And I think that more so than anything else, that gave me the opportunity to not only crystallize, but it was like a crucible of actually understanding the journey that was possible before me. Because in Atlanta and in Morehouse in particular, in that setting, there were guys from all over the country. Other African-American guys from LA, Chicago, Texas, Florida. And in that little crucible, we ended up understanding that there was greatness amongst you. And not only for those who were with, but those who were ahead of us that came back to speak, whether it be some of Dr. King's associates like Joseph Lowry or Ralph Abernathy. You had Dr. Andrew Young, who was the former mayor. On Tuesday and Thursday, we were exposed to some of the guys that actually had set forth a lot of this journey before us. So it was an experience that helped me understand that, being able to be in this journey from a HBCU process, actually catapulting it, because most of the guys that I was there with went on to other majority institutions for graduate, professional, dental, medical schools. And it meant that when you got there, you were comfortable in that setting as far as the challenges and the competition that you were going to get, because you'd been in the heat of the battle, competitive but loving in the HBC portion that we were there.
That's great. That's great. And at what point in your time at Morehouse did you determine that you wanted to go down the path to study dentistry and become a dentist? And during that path, I mean, it's very noted that the field of dentistry is not very diverse as it relates to the number of dentists that are in that field that are persons of color. And so the first part of the question is, when did you decide to go down that path of wanting to be a dentist? And 2, as you went through dental school and to the higher levels of education, being one of the selected few who was African American in the program, what challenges did you see there as far as acceptance or those types of things?
Well, in Atlanta, when we were there, I would say that between my freshman and sophomore year was the determining factor of going forth from the medical, the dental side. I had been exposed. I had a cousin who was in Austin, Texas, that was a dentist. And during my high school years, I was able to spend some time down in Austin at his practice. So he was in a group practice, and he allowed me to come in and, empty the trash and watch from the back and be a shadower of sorts, but also to help kind of crystallize whether or not I wanted to pursue that, to really understand that it wasn't, fun and games, that it was definitely a love that you had to have to do so. And that was pretty much the impetus. And at the Morehouse situation, when I was there, we were in a situation where we had a lot of guys, because again, it's an all male school. So we had a lot of guys that were also pursuing that. And it allowed us to have, between the medical stint and or the dental stint, we also were exposed to those who were alum in the Atlanta community. We would go out to an oral surgeon's office and have exposure to what oral surgery was outside of, the didactic portion. Because there were other guys that were in the area and they were willing and committed to having to pass that baton to the young men that were coming behind them. So that allowed it to really begin to crystallize. I had a gentleman who was probably one of the things that I just said on my journey. There's always been an African-American male that has stood in the gap, that has allowed me to kind of stand strong and kind of saw something in me for whatever it was worth. And there's a gentleman was Dr. TJ Blocker. He actually was one that walked with us as far as the whole group, because as I quickly pause, when I graduated from Morehouse, in our class, currently as we stand now, there was about 45 of us that either went to medical or dental school out of a class of about 400. So close to 10% of our student body went on to professional school. And it was because of the way that the arrangements had been put forth, both institutionally as well as in the community, that really afforded us a real opportunity to make some headway in areas that, as you were mentioning before, as of 2020, I think that there's probably only about there's like 201,000 dentists. It's like 2.6% are African American, which is roughly a little under 6,000 in this country that are currently practicing dentistry as we sit here tonight.
Wow. Yeah. And I do want to, in a bit, get to that and kind of, get your perspective and understanding of the impacts that has, particularly in heavy communities with persons of colors and African Americans, and them understanding, how to handle those communities. How about your time at Temple? Getting away from Morehouse, where it sounds like you were in a very supportive environment, had good mentorship, good leadership in helping you along. Any differences once you got to Temple?
Quite. I'll just say that.
Yeah.
From a historical perspective, two things happened. One, I got to Temple. I was initially at Fairleigh Dickinson University School of Dentistry during my first 2 years. But at the time we were matriculating, both Fairleigh Dickinson, Washington University out in St. Louis, and Georgetown were closing their dental schools. So I got caught up in a situation where they were not finishing us there. We had to actually go back into the cycle of locating another school. Being a Pennsylvania resident, it allowed me to actually apply here and actually go to school at Temple and get in there. My buddy from Morehouse, who was also my fraternity brother, he and I were the first two to ever transfer into dental school in the third year of Temple's program. And additionally, from a historical perspective, the gentleman that I eventually worked with down in Delaware, he in the early 70s was one that had got accepted into Temple's dental school. But at that time, there was another African American that got accepted, and that was Dr. Eddie Williams. So between the two of them, they ended up only allowing one of the two to matriculate through the program at that time. The one gentleman had to go in and do a pharmaceutical and sedation, basically a rotation before he could go back in the next year. So it was at a point where early on, Temple was not too friendly to multiple levels of color being actually in the ranks. When I was there, we had 110 students, and it was like 5 of us in my class. Wow. So it was a situation where when we arrived, my roommate and I, we were pretty much told and kind of pulled to the side by one of the instructors who was a naval a former naval officer down at the shipyard, and he said, son, if you really want to make sure that you handle your business and you stay, without too much to do, you want to strip that nameplate, because these have like these carts that have all of our instruments in them and our names, and from Fairleigh Dickinson. It was really a nice setup. It was gold. It was and in wood casing with everything on it. He basically said, look, you need to be able to be under the radar here. Don't be, outside the scope of anything or anything, because folks don't want you here in the first place. And that was pretty much in the first 2 weeks that we were there. It was very clear that you need to kind of keep your head down and just get through the program.
Yeah.
And that was kind of one of those scenarios that was showed up from a standpoint. But one, even before we came in here, my first roommate up at Fairleigh Dickinson was a gentleman who was a little older amongst us. And he was a guy who was probably like Michelangelo with his hands. And we had to wax the shapes of teeth, the morphology, and all things of that nature. And while this guy was probably as good as anyone I've ever seen, there were people in our program who probably weren't quite that adept. So he would sell basically the opportunity for you to have him wax for you, so that it would be turned in for a very subjective, grading criteria. These gentlemen that would pay him, $100, $200, whatever it was for that going rate at the time, would come back with, 90s and 95s. And then he would turn his own work in and would be given 75s, sometimes 80s. And it's like, this is the guy who created the other guy's stuff.
Right.
And because they understood where you sat in the room, they knew who was where. And they just basically, even though we all walked out the room at the time of the grading process, it was very much along the lines where you kind of understood and knew you just better get, do the best you can and keep your head down and get on out of here.
Yeah.
Because if you started creating too many waves, then that subjective aspect, there's obviously the didactic part that's objective, but the subjective part in dentistry or dental school was more or less the things that you had 4 or 5 instructors that you had to go through for one particular project, that if any of them happen to say he's not going to make it, that wink, wink kind of nod, nod situation, then you would either find yourself on probation, suspension, or possibly actually removed from the program.
Yeah. Thank you so much for sharing that story. I mean, one of the things that we really focus on with Common Bonds is, as you know, and all of our followers know, we have monthly topics that, we share through data and facts, the inequities that occur based on color and based on being African American. And it really reinforces them when you hear the personal stories firsthand. So I really appreciate you sharing your insights and knowing that it was probably in the mid-late 80s, so it wasn't that long ago. It's sad. It's very, very sad. I want to bring the conversation up a little bit and get your perspective. During the month, we really shared a lot of information and data on the inequities we see with health, particularly within the African American community, and wanted to get your perspective and maybe educate. I think a number of people on the call do understand why there are inequities in health for African Americans, but a number of other folks may not understand fully what's behind the data and facts that we've shared in regards to why African Americans have a significant amount more of health issues than others. Can you share a little bit from your perspective, both in your upbringing as well as with your practice, working in Philadelphia, working in Wilmington, 2 urban areas? What are some of the drivers of the inequities that we see from a health perspective?
Well, as you imagine, it's multi-level, and it's almost like peeling an onion in terms of the layers that we actually are actually confronted with. Part of it, obviously, is socioeconomic. You have arrangements. If you just think back to, water situation in Flint, Michigan, or, access to care. And, even within the access to care that's available at times, the practitioners that are being the servers are not, blatantly racist of any sort. Most of them are just fine, but it's just that the system itself is not really designed or set up that will allow those opportunities for when you're interacting or seeing others that aren't quite like you to understand where they're coming from at times. So, the whole healthcare scenario that we've been exposed to, I think, Mike, has been, over the period of time, multiple, drop-off points. As far as the lack of trust, as far as, the fact that people don't like to listen necessarily to what is being said or spoken, or coming in with preconceived notions of what somebody is or isn't. Your pain threshold level is different than mine because I know it's, that's just kind of how you guys are or whatever. So there's a variety of things that are hindrances and are not always as welcoming as they might otherwise be. So, what we've seen too often is individuals who might come, but they'll have waited a lot longer to actually seek out care in terms of, instead of preventive or maintenance scenarios, it's much more acute, or situations where what used to be a chronic, I'll get to it, if it ain't bothering me to the point where I can't go to work, I'm just going to keep running through it. When that typically will occur, it'll blow up. And as we know with anything, any chronic inflammation, any continual issues that will untreated or unrendered will eventually break the body down. And that lends itself that, we obviously are dealing with much more of a morbidity and mortality rates that are just different across the board with each of the individuals in the cities that we talked about, as well as, even within, the outside of the urban areas, more so even in the rural or even suburban lakes. So those are some of the things.
Yeah, it's a great point. And I think it's one of those areas. I think what we are all learning through this journey, particularly what I'm learning a great deal, is that racism is not specific to one area. It's a cumulative amount of other areas that cause those areas to be that much more significant than alone. So as you mentioned, from a health perspective, it's the socioeconomic aspect of things. It's the employment aspect of things. It's the housing aspect of things, and the location of communities near toxic plants and those types of things. So I appreciate you sharing that and educating folks that, each of these topics on their own is disturbing. When you tie them all together, it really backs up the data and the facts of the issues that we have and how we have to work on those. So thank you. I want to go back to a stat that you gave us that was eye-opening, and we had Dr. Joy Cooper on last week, who also gave us an eye-opening stat. She's an OBGYN out in Oakland, California. She told us that about 5% of obstetricians are African American,
Mm-hmm.
and you mentioned that 2.6% of dentists in America are African American. And so, as we talk about the understanding of the African American patient and all of these different issues, and one of the blessings we have with our Common Bonds followers is we have a lot of healthcare professionals who've joined this month, and many of them are white. Can you help advise them and advise all of us that, with many dentists and many healthcare professionals who are white providing services to African Americans, how can they have more empathy or more understanding of the experiences that African Americans go through and help them with their health challenges going forward?
Oh, Mike, I would say that one of the things that we all typically like to kind of understand, even in my journey, I'll just explain my situation first, is that, we have patients in our practice. We like to make sure that we take the time to listen, and learning to listen, not just hear, but actually actively engage in the process by which somebody's coming to you without, predetermining what the situation is before they finally get a chance to express them, is one of the things that will help the trust factor become the bond. Because again, being that I've been at this game a little while, it lends itself that it's not so much, transactional. It's about being relational. And if you can be in a relational, because each person who sits in our chairs and our seats, that gets done work done, there's a soul behind that individual. And the aspect of the things that they're going to be dealing with, you have got to sometimes take the time in order to understand and appreciate, what's behind them and what's going on in order to really gain access to, that next level. And having an open attitude, I think, Mike, is one of the things. In addition, learning more about your own situation, your own self, a little bit more of a self-awareness is helpful to the understanding of, in essence, is cultural competence, or understanding where folks are otherwise at on their end. It plays a role to making sure that you can kind of help, get to that level of how can I break through this barrier, or get to a level where, we're able to kind of have a more amenable communication between us. And I would say also maybe interacting with other diverse groups to develop somewhat of the cultural knowledge that individual can help, and it's like this. As a professional and as a, a practitioner, you have to have tools in your toolbox, on your tool belt, basically. And if you can add more tools on your tool belt, you can solve more problems. You don't have to be MacGyver, but you certainly want to be, better suited than, Peanut from the comic strip. So I think that's one of those other things that helps to kind of bridge that gap, and it takes time, and that's the thing that we don't have much of anymore.
Right.
And the relational situation is different now because there's certain outcomes and things you have to have in your flow of your day, and it's difficult because again, time is money, and sometimes that's the mindset that people go into the operatory with, and that sometimes is a challenge.
Yeah, it's a great point. It's a great point. And for the audience, again, just a reminder, if you guys have any questions, as we're going along, please put them in the chat. And
Mike, let me interrupt you real fast.
Yeah.
I'm sorry. When I made that quote, or the numbers 2.6, that's the same number as it was in 1972.
Right. Wow.
So we're talking what, 50 years later?
Yeah.
We really haven't done much.
So let me build on that, because that's where I wanted to go with kind of two additional parts to that. So what has to be different? Why over the course of 50 years has that not grown? And what do we have to do different as a community, as a society, in order to increase the amount of African Americans who are getting involved in some of these critical areas, healthcare and some other areas? What are some of the things you believe we have to do in order to improve on that we can help drive with Common Bonds and our followership?
Well, I mean, I think that we're at a point where it's not about talent. It's not about intelligence. It's not about, those things that would normally, be somewhat of the hindering or stumbling blocks. I think most of it is exposure to being in those fields that allow you to be able to shadow or to have some sense of what is this really involved to drive an interest. STEM obviously is very important in order to get access to those things. And so a strong piece in the STEM part will certainly help. More so than anything else. And this is the nature of the beast, and this is the reality, is right now, the greatest hindrance to the majority of folks maybe edging this up is the cost of education.
Mm-hmm.
You're talking coming out close to $500,000 that are in debt. 400 something thousand. I had a nephew that was in school, just finished a few years ago, and he had $437,000 before he did anything. That's a payment on a McMansion. So how many, if you go to B school, if you go other places, certainly there's some debt to incur. But the nature of the beast right now is that, when people see what the cost is, a lot of times they're like, hold up, I think I might want to opt to go to B school or maybe in law school, but I'm not going in there and coming out. In medical schools even more sometimes than the dental piece. So I think that continues to be a great hindrance to, to actually getting into the game.
Yeah, that's a great point. And just to give everyone a little preview, our topic for February is going to be education. And these are some of the speakers that we're looking for. We're certainly going to want them to talk about you mentioned STEM programs and development programs at the, especially at the high school level and going into the college level. But the cost aspect of it is, as you mentioned, I was chatting with my physician about a year ago, and he was telling me that he had finally paid off his student loans.
It's a great day.
Happy about that. And he was 49. He was 49 years old.
Yeah.
So clearly, you're right. That's a large issue we know overall, but even more exasperated with folks who haven't had the opportunities to socioeconomically be in a position to be able to afford any college and have to take out those loans. Just building one on this, and then we'll switch gears a little bit. So, as we were talking earlier about the 2.6%, and I was mentioning that we have a number of folks who are white who are on the call that are looking at ways to better connect with their patients regardless of their race. Are the schools today, speaking of education, working on anything formally within their education systems on how to interact or how to show empathy and some of the things you said with folks that have a different upbringing, a white person understanding a person of color, or understanding somebody who may be LGBTQ? Is there any formalization as you're going through dental school or your knowledge through medical school that's addressing those things, or is that another opportunity to formalize that as a key part of their education before they go out and start practicing their profession?
Well, Mike, I think it depends upon the actual institution. Some of them are very proactive in that fashion. Some of them are really going and digging into that and actually embracing it as part of their curriculum. But I would still say that a large majority of professional schools, medical and dental schools, with the load that you have in other areas of curriculum, that tends not to be just like, the business portion of how do you run your business when you get out. They'll give you the MBA level course at the back end, and it's like, well, I got this requirement, or I've got this to do. How realistically are they really making it a priority? And that's really where I think the difference is. On some of the institutions, Temple's beginning to do a much better job as well. They've heard that, and they've actually begun to actually help to change part of that the third and fourth year curriculum in that respect. And a lot of times before the students begin to see patients, as opposed to, okay, now you're seeing patients, now shift gears. And because in the experience that I remember in Temple in North Philadelphia, certainly the majority is in a predominantly minority community.
Right.
So that means that the patients that were coming into the clinics were majority minority. But at the same time, you had some attitudes and some perspectives of the other, students that were there that were, there was nothing more than just a set of teeth. That's giving, I need this amount of, requirements finished. So, but as far as the person behind that, it really wasn't that respect. Sometimes you lost the respect of the individuals that would just do certain procedures and certain things, knowing if that was their own family, their own sister, brother, or family member, would you really put them through that? And that's the question that you often had to ask.
Yep. Yeah. No, that's great perspective, and appreciate you sharing that. And I want to change gears a little bit, because I know, the number one issue in our country right now is the pandemic. And we see on a daily basis, and we and in a lot of the data that we shared this month as well, that there clearly is a much larger impact of the coronavirus on the African American community, both in contracting it as well as passing away from it. I think we see 3 to 4 times as like African Americans are as likely to contract the virus as well as die from the virus. Can you share a little bit of insights as to why that is? And from your perspective, what are the things that we need to do in order to address it and prevent that from happening in the future?
Well, again, it's like a peeling of an onion, Mike. There's a lot that goes into this, and we talked before about the manner with which the United States healthcare system is set up. It's more of a, for lack of a better word, it's almost like a sick care system. We don't tend to look to be health-wise or driven. We're just basically tending to the disease in a fashion where we're not necessarily getting to, the resolution of health. And I think that's just the greater society that, with minorities, a lot of times, we're not always treated as evenly and equally as such. And with this particular aspect with the coronavirus and with the contraction with minorities in particular, obviously those of color and Native Americans, being in the rural areas of getting swiped because of lack of local hospitals in and around you. You've seen some people having to drive, 80, 90 miles in order to get actual care. And in that situation is different than obviously being in an urban center or in a city, but no less deadly and lethal. From a historical perspective, I think that there's been somewhat of the distrust that has been present in amongst the minority community with the vaccine situation. I think we reflect back on Tuskegee, we reflect back on some of the things that took place during slavery and other times. I think Dr. Joy may have mentioned something along that line when she was speaking the last time that she was on. But the biggest challenge, I think, is to not let those ghosts of cloud judgment and reason in order to seek care and to be available to kind of make sure that you don't become just another statistic. But because of the fact that access financially being able to take care of things and just deciding, what do I pay for today? My light bill, my heat for my children, or food in their bellies? Or do I go ahead and, get the medicine, or do I go ahead and do other things? That's a tremendous predicament that so many people are actually facing, and it's real.
Right. Yep. And it goes back to what you had mentioned earlier, and again, how all the aspects of racism from a socioeconomic perspective, from a housing perspective, from an employment, all come together and are definitely driving some of these issues and the root cause of these issues. I want to ask you to build a little bit on, I think this is a really critical education moment for some folks on the call. I know other folks know this all too well, but you mentioned about the vaccine, and you mentioned about African Americans' hesitancy about getting the vaccine. And we've seen a lot of statistics that say, 50 to 60% of people are comfortable getting the vaccine. I think the number's going up, but the African American population, only about 30% of them are comfortable. And you mentioned Tuskegee and some of those. Can you elaborate a little bit on the history of what really has occurred as it relates to vaccinations that has caused the African American community to have such apprehension about getting a vaccination and the intent of it?
Well, Mike, I think that, when we reflect back on the Tuskegee situation with the syphilis that was allowed to go untreated, having that as a subset of where people's minds are at, if I guess in a minority community, part of what we're seeing to some degree is typically you're not offered the opportunity to get anything first. So why now? Why are you saying get this vaccine first? Make sure you get it. So you're kind of having a reversal of the mentality or the mindset that in years gone by, it's not been those of minority, those of status, of the least of these getting the opportunity to get the best of this. And so I think that has a large portion of people not saying, you know what, are you really sure we want to do this? Mm-hmm. But our call and our cry continually right now is follow the science, and the science seems to be quite legit. And that's the thing I think that, was encouraging this week as we talk about. There were some people who I talked to, a few weeks ago, like in the latter part of December and the beginning of this year, and they were like, they were heeing and hawing. But when I talked to them this week, they were like, you know what, can I get it? Where can I go? And they're actually changing their minds, and the mentality is I think, that a very big upswing relative to actual acceptance and desiring. The big challenge now, Mike, is there's not enough of it, as far as access to it, so it's like, now that you want it, it's tough. Yeah.
So let me dive into that a little bit, because, what I mentioned at the beginning of the call is thanking Vince for taking the time when there are tremendous other challenges there. And I know you've been one of the leaders within the dental society within the Philadelphia region on making sure that the dentists who are considered in 1A first responders or 1A medical professionals who need the vaccine immediately, and some of the challenges it's taken for them to get it. So kind of a two-part question. One is, from your perspective and your experiences recently, what are the reasons why? Is it solely that there's not enough supply, or there are other reasons, particularly in getting it to the African-American community? And then secondly is what do you see as some of the opportunities going forward in order for us to accelerate it? And is there a kind of, from your perspective, a light at the end of the tunnel, or are these challenges that we're still going to be experiencing in the near future?
Well, Mike, I think it's a multifold piece in that public health has been gutted over the last several, decades almost, in terms of the availability of public health. So right now they're underserved, under-resourced, and overworked. And as a result, most public health systems in this country are unable to really step up to the plate right now and do what they're being asked to do, which is to distribute the vaccines at a level that is going to actually get most folks, 70-80% of this nation vaccinated in a reasonable time. And I think that's number one, is that a re-emphasis on public health. I mean, if nothing else, this pandemic has really brought to light the fact that this nation, unfortunately, has been remiss with managing the public health system. Just think back to when Salk and the polio vaccine and how many, I mean, none of us were around, obviously. I think Dr. Fauci may have been the only one that was around in New York. I mean, how active and engaged you can do 2 million people in New York in a short span of time that they were able to, anybody was able to step up and get that. The mayor was probably given, vaccinations to his constituents. But now it's been a rollout that has not gone well. It's uneven. And unfortunately, they should be working out the kinks as best they can. But I just think that each state now is, Pennsylvania, New Jersey, and I'm here in Delaware, it's been a different tact and a different layout of how is this thing going to be distributed. I'm speaking on a frustrated level of the 1A grouping where I'm at here in Delaware, in the sense that, I've still got colleagues who have not received the first dose yet. And, they've been turned away, and, it's like playing whack-a-mole at times, unfortunately, trying to actually, figure this thing out in a level, because we've now moved to the 1B group. And I just am hopeful that we can kind of get some resolution where, as we open it up, they're saying April, May for everyone, that we can have, a little smoother, learn from our, shortfalls, and kind of get this thing at a point by which, get the shot in folks' arms. And we're able to actually move this ball forward, because we're not going to see, life as we usually knew it until we get some sense of, having this as a backdrop. And Moderna and the Pfizer are the 2 primary drivers right now, but they're 2-shot situations. And the J&J product will probably be out in 2-3 weeks now. That's a 1-shot situation, but the J&J is probably closer to what we would like to probably see as the driver for this,
Right.
Because compliance with anytime you're asking somebody to do something more than once, you're not always going to get 100% cooperation, obviously. So, it'd be ideal if Moderna and Pfizer are able to step up to the plate until they can, pass the baton to whether it be the AstraZeneca Oxford model and or the J&J. A couple of them have just bailed on the situation.
Right.
I think it was good
Merck.
gracious, up in
Merck.
Merck today just announced they were not going to do it.
Yeah. Well, I think the hope for all of us is to continue to hope and pray. And, I know hope is typically not a strategy, but in this case, that we can get more doses and execute on it, but then also take the learnings and build an infrastructure that it never happens again, certainly not only for our generation, but for generations to come. So thank you for sharing that. I know, again, you're in the front line of defense or offense on this, and I thought it would be great for the group here to hear your perspective on it, and some of the challenges that we continue to have, as well as the opportunities with the J&J and the AstraZeneca vaccines, hopefully coming shortly, and providing more doses as well as single shot capabilities. So I want to get to some of the questions. We got them piling up a little bit here. So the first is from Marissa, and she says, "Thanks so much for your perspective. As I listened to you discuss your experience at Temple, I was dumbfounded that those things could happen in such recent history. But I know from her conversations and from talking with April, and April it has been such a wonderful educator for us. Can't say enough about how she really has led this initiative and helped many of us. For African Americans, not that surprising. The question is, for those of us on the call who consider ourselves allies, how can we better educate ourselves to confront racism in healthcare when we see it?"
Well, I think what I mentioned a little bit earlier, having a good background, or at least some understanding of recognition when it does occur, and giving, I guess, whether it be through your business or your department, the understanding that you can lobby for others or on their behalf in some form or fashion, I think will make a difference whenever that might present itself, as opposed to letting it go and just saying, "Man, that just wasn't right. That doesn't feel good the way that looked like," and actually having some means or at least ability to say, how might I, even if it's not that time, the next time, be an agent of change, or at least be in a position to say, you know what, I'm going to take this to HR, or I'm going to do something that, even if it's on the side, that you can have an impact, I think might make a potential positive change for where you're at.
Yeah, I think that's great advice. And I think while the question was focused on healthcare, I think it's across the board as it relates to racism is listen, learn, and lead, take action, speak up. And that's one of the things that I think we've been continuously reinforcing as part of Common Bonds, and particularly as we educate our white allies and moving them to be anti-racist, is how they can be proactive in helping address these situations as they see them occur. So it's great advice. Thank you. Pinellas, a question: rural communities seem to struggle and communities of color struggle more. Is there a fear of dental care, and what can be done to combat the high cost of dental care?
Well, I would say certainly there's a fear of dental care, especially, one of the things we've seen, is that if you had a bad experience and you bring that as a youngster, as a child, into your adulthood, you are more than apt to be the one that say, you know what, man, that's like a flashback. That thing was such a traumatic torture to me. Then you're not going to, stand up and want to go for a routine maintenance cleaning or a checkup, because you're fearful of the fact that that pain was real. And I think that's the reason why helping to get the younger generation, when they're coming to the dentist, at a point by which it can be a more fun experience, or experience that is not laden with, an abscess or some infection or extraction, introduces them to something that, it could be lifelong in terms of for a benefit, that they themselves understand that, everything that I eat got to go through my mouth. If I don't have any teeth to go through there, then a lot of times that's going to affect my overall health in terms of what I can and can't masticate or chew up. My digestive system is going to be, not the way it needs to be, and, a variety of things. So I think that, helping to, get that is one aspect. The challenge, unfortunately, from the second part of the question, as far as how can we kind of change the dynamic of affordable healthcare or affordable dental care, that is, if you can solve that nut, or if I can solve that nut, I can retire tonight. If you look at, other nations and other countries and how they've addressed this, it's the fact that we're kind of the outlier across the board, whether it be medical care or dental care. We just, as a nation, kind of have been driven by a lot of the cost that it goes associated with it, and then it develops a have and a have not situation. If you don't have the ability to go to the dentist because it costs too much, then certainly the end game is that you're going to have dental issues at some point in time. Yep. And then it's a matter of, I got to take this tooth out, as opposed to getting it dealt with on the front end. And it just is, it's a self-fulfilling prophecy over and again, unfortunately. Yeah.
And to build on that, your practice is in Wilmington, which is a urban area. What is the inequity in patients that you see based on race that come in for preventative care? So, I mean, you talked about the hesitancy. If you have a particular issue that happens, you have to get that issue taken care of. And it really goes back to, how do you avoid the issue? And if you come in for preventative care, you have an opportunity to lessen that, so to speak. Do you see a large discrepancy between whites and persons of color who come in for preventative care, and subsequently then a higher percentage who have to come in for more reactive and significant care in your practice?
Well, in my practice, I've got probably a breakdown of about 65-35, and then 65% Black and minorities, as well as 40% Caucasians, whites. So the numbers in our area are not substantial like it would be in Center City or like West Philly, or looking like in North Philadelphia, where that would be more of a driver, I think. But there are some that, because of lack of dental IQ, because of how they were raised, even though, like, I'll say, for instance, there are people who have worked at the Port of Wilmington who have excellent benefits and care. However, because they've never really, from their childhood to their adulthood, sought out dental care, they've had these benefits, but they haven't used them. And they're coming in at times where, a tooth is blown out and they just want to get it dealt with, or, or they're running up to Chester sometimes to just get some work done real fast. And so as a result of that, you're seeing a multitude of people that, because of dental IQ or dental awareness, sometimes fall into the cracks of those of which who may not have even had the insurance or had the resources to go. And I've seen that kind of carry through a little bit. But for the most part, those who of color that we've seen that have come through, it's a smaller percentage than you might think typically.
Yeah. Well, that's good. That's good. Do you do you see the same with overall healthcare? So in your just experiences within the Pittsburgh growing up, and then Philadelphia and going to school, and then now in Wilmington, similar to what you mentioned on the dental care piece, and the insurance aspect, et cetera. Do you see similar on the general health side, that there's or what's the difference? I think the answer clearly is going to be yes. But what are the inequities that you see from the African American community engaging in preventative care versus the white community, and are the drivers similar to what you see in the dental side?
Well, what we're seeing, I mean, we've just, as of this past October, Delaware was introduced to adult Medicaid or adult dental care for the Medicaid population. Prior to that, we had none. You had just for children, but nothing for adults. Whereas in Philadelphia or in Pennsylvania and other states, that's been pretty standard for a good part of the time. And as a result, you're seeing a little bit better, end games or outcomes as a result of that, because now you're having the access to get, the disease that might otherwise be untreated is now being addressed and handled for those individuals. The medical side, because Medicaid, for those who may not otherwise have traditional insurance, at least has had some sense of, I can get certain things done. I can have my medications. I can at least be able to see a primary care and have access to some things. But across the board, there's certainly, a discrepancy with those who have been without. And like I said earlier, do I feed my children and keep the heat on? Or do I go ahead and, spend this extra amount of money to, do a routine preventive care? And I think that still is a major factor amongst those who, from a socioeconomic standpoint, take out the fact of do I, am I fearful, or do I have other, trust issues? It's just a matter of, hey, I can't afford to go. So why are we even having this question or conversation until they show up at the emergency room or an urgent care facility? And just to kind of band-aid that situation, that is, a lot of times we'll have actually seen or addressed. But medically, I think it's a little bit further ahead than the dental portion. Mm-hmm. Dentistry is still like the stepchild of the medical condition sometimes, not thought of as part of the team at times. And as such, that's kind of how people have addressed it. It's like, unless I'm in a gurney and wheeled in on the ER, I'm just going to handle it, stuff something in there I find at my drugstore or my pharmacy, and possibly, manage myself until, an abscess develops, something that becomes, cellulitis, and certainly could be septic. And ultimately, there have been issues where folks have actually passed away because of untreated areas where there's been infection that has not been remedied.
Wow. Yeah. And Fennell has a question here that I think builds on some of that and builds on the comments that were made before as it relates to the reasons African Americans have more health issues, and the perception, the wrong perception that the pain thresholds are higher. And I think it might not be the wrong perception because it's had to become that way, but clearly it's not the right perception overall from a medical aspect of it. So Fennell brings up a great question in relation to that, is how many children get exposed to laughing gas and other things that make the experience good for Black children? If that doesn't happen, there will be no follow-up.
Well, I can't speak specifically on that. Depending upon, again, from a pediatric dental care situation, the laughing gas is often combined and or used with a oral sedation process where you have like a Kool-Aid kind of mixture besides the actual anesthesia that's given to the child. That often is kind of the combination if in fact somebody needs more than the traditional shot or anesthesia that you normally receive. But that is a little bit different, I think, because the majority of folks who actually are receiving it in the pediatric situation would receive it probably more prevalently than those who are receiving it in a general dental office that sees children through adulthood. I just think that the management that takes place in the pediatric office is a little bit changed compared to where we were.
Got it. Got it. Thank you so much. So one final question is from Matt Scott. Last week we touched on food deserts in African American communities. So we talked really about some of the challenges in African communities around health is the lack of access to healthy food,
Yes.
even grocery stores, etc. Do you see that evolving in your dental care practices as well, or in your when you're looking at folks who live in those communities that they have additional problems because they may be eating more sugary things or fat related things, et cetera? Is that, we certainly focus on it and see it on the health side, but I would imagine it's an issue on the dental side as well. Can you share some of your insights on that?
Oh, without a doubt. That's all part of the body is a whole being, and we don't often separate one to the other. And nutritional, value and the manner with which people are eating or not eating, and sugar in particular is not only does it affect obviously the extra weight that we may possess, but from a standpoint of it actually being through the mouth and the oral cavity, yes, we will find that that's the case. And if we're looking at food deserts or lack of fresh fruits and vegetables that would otherwise be a primary manner of eating that a child or an adult would have, it will turn out to often become a situation where they will be more prone to the breakdown of the tooth structure or the gum situation as far as periodontal issues. That definitely has been part of what we've been trying to see. So when we deal with assessment and evaluation, a lot of times we're also asking, nutritionally, what's your favorite food? What do you like to drink? Is it water? Is it juice? Is it, Gatorade, Powerade for some of the young folks who are athletes? Because we'll start to notice that they'll have cavities that will develop in areas that will be because of the fact that, that's one of the main consumption, not just water, but, that sugary, acidic nature will actually create situations that will make us have to say, hey, let's just, assess, because when a person comes in, we want to say, are you a low caries risk, a medium or moderate, cavity risk, or are you a higher risk? And as such, that makes us, from a hygienic standpoint, say like, let's emphasize this or that or the other to kind of manage that and kind of get them back to health.
That's great. That's great. I appreciate the insights on that. We have no other questions. So, what I'd love to do, what we ask all of our panelists or our speakers to do is kind of give your insights in closing, and then we'll hand it over to April for some thought. But, one of the questions really is, or a key question for all of us that we like to finish these sessions with is an action related question. And, overall, with healthcare as a whole, and certainly dentistry, which your expertise is in, as a community, specifically the folks who are white on the call, who are being continuously educated on these situations and biases, what can we do as a community to educate ourselves more on health inequities, as well as actions we can take to drive a more equitable healthcare system? So I know we addressed that a little bit before, but any kind of closing thoughts that you have that can help us feel empowered to take action going forward?
Well, Mike, I would say that, part of it, what we talked about a little or touched on earlier, sums up part of that experience, but just educating ourselves as far as with these things that are out there or that are present within the community. The fact that, we've got, the health issue it's a nut that has so many layers to it as far as, the causative effects and how it actually presents. It's something that even if it's a small engagement of sorts, and you're able to really maybe drill down on whenever you have seen something kind of play out, how would you put yourself in that situation? If you saw something occur or you're assessing something, would it have been the same if it was myself as opposed to that other person that I'm seeing from across the room? Or is it a situation where I'm saying, this in casual conversation, I know it was a little difficult now with regards to everything being like we are now, zoomed out, or being on, Google Meets and things. But when we get opportunity to get back on board with our, coworkers and neighbors and friends, as we speak or as we have conversations with them, just kind of gently or, kind of systematically, maybe just kind of ask these type of questions of, what is that experience like? Or have you been able to, since you were a little girl, little guy, been able to go to, have these things? And you kind of get a more app of understanding that, it's not everyone, obviously, but it's a fair number of individuals who've probably had something similar to what we've discussed tonight that has been their experience. And, obviously I know the American Dental Association has recently placed out issues that we're talking about from inclusion as well as from a diversity standpoint, trying to manage those expectations that, heretofore had not been, talked about publicly. They were always being talked out behind the scenes. And it's now time for, from our perspective, to actually make it a situation where we are actually addressing it in the fashion that it really desires and it really is required. So I don't know if I really added any more to that, but that's just part of it.
Yeah. Any other closing thoughts you have that you want to share with us?
Well, I would just say I appreciate you guys, and it was a wonderful time spending this hour with you. And if there's anything that we can do to kind of continue to support what Common Bonds is all about, and I'm all in. We'll say that.
We appreciate it very much. I'm going to hand it over to April, who's going to give us some additional thoughts, and then we'll wrap up. So thank you so much. April, over to you.
Thank you so much. Thank you, Mike. And Dr. Daniels, thank you so much. You've been so very gracious to share with us this evening your experiences. And you said something that really stuck with me, and it is so very true. You talked about your experience at Temple and how some of your colleagues, your Caucasian colleagues, sometimes forget that there are souls sitting in the chairs. And that really stuck with me because that's really across the board with racism, that there are souls behind every racist act that happens, be it killing, be it discrimination in public schools or hospitals or housing. There are souls at stake. And so I definitely thank you for sharing that, because it brings it really home that that there are lives that are being affected with every act of racism. So thank you so much, Dr. Daniels, for joining us tonight. Thank you, Mike. I really do appreciate you. And just as much as you say that I teach you, you definitely teach me and are causing me to want to continue to be brave and come out of my shell to kind of trust. And I think, Dr. Daniels, you talked about that as well. A lot of times you said it's an onion and it's layered, and the situation is definitely has a lot of entanglement. You call it an onion, I call it a bird cage. Each metal has a specific reason why this thing called racism exists in America, and trust is one of them. And so, yeah, I thank you, Mike, for causing me to come out of my shell and to trust enough to be honest and open. And I want to also thank our Common Bonds community for your continued learning, your continued support of Common Bonds. And thank you so much for your willingness to become allies and your willingness to help. As we learn, I think that is the key to really be open to understanding other people's perspective. And the more you do that, the more it hits home for us that, yeah, something isn't right, and I can do something right where I am. And so thank you, Common Bonds community, for being willing to do that and to be that. And so I would ask guys, so next month, our focus is racism in education. And Dr. Daniels, you talked a lot about education and the discrepancies or discrimination there. But next month, we're going to talk about racism. So guys, keep a lookout for for your emails and for on social media platforms. We'll be highlighting different types of racism in education. And I just want to end on one thing that Dr. Martin Luther King said about education. And he said that the function of education is to teach one to think intensively and to think critically. He said intelligence plus character, that's the goal of true education. So that is really something that I take to heart. It's not just about what you know, it's not about how much you know, but it's about how much you care. And so that is the goal. And that's our goal as we continue this mission, as we focus on what causes racism against African Americans and what we can do together as a community to help drive change. So thank you everyone for joining us again tonight. We look forward to seeing you next month. And if that is all, nothing else, have a very good night. Be safe. And we'll talk to you guys soon. Good night.
Thank you.
Good night, everybody.
Bye, guys.
Thank you.
Good night.
Thank you.